So early detection of pancreas cancer is challenging, and this is one of the hallmarks of its disease. It's insidious and often not just locally advanced, but often metastatic at the time of diagnosis. So when one can screen effectively for this disease, that'll be a key step forward. And right now there are a lot of challenges, not least of all in terms of who's the population that should be screened, how should they be screened, and what frequency should they be screened. Groups of people that might be at higher risk for this disease are groups of people that are potential screening candidates. So, for example, people with a familial history of pancreas cancer, so where it's known what the genetic association between family members is, or even in families where there's a high risk of pancreas cancer but there's no known or at least identifiable genetic mutation. Those groups of people are good candidates for potential screening. And a variety of techniques are entertained. The main one would be MRI because of no cumulative radiation exposure. Endoscopic ultrasound is used to follow up on abnormal findings on an MRI. It's an invasive test, so that's, wouldn't say it's done routinely, but it's certainly done in conjunction with MRI or sometimes alternated for screening for these patients. And there's some data looking at alteration of blood vessel density around early pancreas tumors and demonstrating a difference using a polarization spectroscopy technique to identify where tumors might be developing, comparing tumors to normal ductal epithelium. But it's still not clear whether that's going to be specific or sensitive enough. And for example, a chronic, or at least a confounder, can be pancreatitis. And changes of pancreatitis can sometimes mimic changes of malignancy. So having something that's able to distinguish those two is a key issue in terms of screening. So other considerations, not so much in terms of screening, but in terms of taking advantage of innovative technologies, would be where do circulating tumor cells fit in the algorithm of care of patients with pancreas cancer, and for example cell-free DNA, where does that fit? And both of those right now are research tools, but several groups, including ours, have looked at circulating tumor cells using a variety of different techniques and isolating these cells and characterizing them. And for us, we've looked at it as an approach to therapy prediction. So isolating CTCs, extracting RNA, and then using a pharmacogenomic model to predict for sensitivity to certain chemotherapies or combination of chemotherapies. And preliminary data has suggested that we can identify in advance people who might be sensitive to a particular class of drugs versus resistant. And this will need to be validated prospectively in a randomized way, but certainly it's encouraging that there's an ability to begin to refine treatment choices for given individuals. In terms of cell-free DNA, that is a research tool right now. We know we can detect it in people with advanced pancreas cancer, but how it should be used and when is the value of serially sampling is a question that's not answered right now.